Okay, our next speaker, you heard from yesterday in the section on vascular aspects of PXE. So Wilko Spiering at the University Medical Center Utrecht, the Dutch Expertise Center for PXE, is up next. And he might be surprised because we're actually skipping over a couple people in the agenda, one of whom told me he couldn't come and I forgot and didn't take him out of the agenda. Sorry about that. And the other, we're not able to reach in time. So Wilko, I'm surprising you.
Yes, you do, but I'm running to my computer because I thought that yours was the next one.
Yeah, sorry. Yeah, George, he couldn't make it, sorry.
Okay. I will start my presentation. Okay, can you see my presentation?
Yes, thank you. I'm not hearing you, not sure. I often say in my meetings, both in PXE and in my other work, Genetic Alliance, that we're trying to solve the biggest problems in the world. And Zoom hasn't solved how we can consistently communicate with each other or meeting Teams or whatever else we're using. Well, Wilko's working on that. I want to again emphasize that our studies that we're undertaking in the form of surveys that everybody can participate in free from your home are really, really critical. All of the researchers that you're hearing from today with information about what is your experience of PXE, and we make really dramatic discoveries. Many of you who have been with us over the years know that we learn, for example, that women who are having mammograms were constantly getting a sense that the mineralization, the calcium that the mammographer was seeing was not cancer like it usually might be, but in fact PXE. And that was a finding because women with PXE told us their experience. Wilko, I'm going to see if we can hear you yet.
Can you hear me now?
Yes, perfect. And I can see your screen as well.
Okay. Well, thank you again for inviting me. And my presentation for today will be on the Etidronate for the treatment of PXE. And for those who were not in the presentation yesterday, my name is Wilko Spiering. I'm heading the Dutch Expertise Center for PXE in Utrecht, the Netherlands. So I'm going to talk about etidronate, which is a kind of a bisphosphonate, as we call this group of drugs. And actually, the group of Junito and Lili already showed quite some years ago that etidronate, in more specific, is able to reduce the calcification that is being seen in these ABCC6 knockout mice, these PXE mice. So in blue, you see here on the left side that in normal mice there is no calcification of the whiskers, and in the knockout mice there you see this brownish calcification. However, when you treat these mice with the drug etidronate, then you can see that this calcification is much less. So the calcification is being inhibited. And when you look at the molecular structure of pyrophosphate, and we learned from earlier presentations that pyrophosphate is the critical problem in PXE. So pyrophosphate is reduced, and we like to increase that or to replace that. And when we look to the molecule structure, then we see that bisphosphonates, these group of drugs, the molecule structure is very similar with pyrophosphate. And one of the bisphosphonates is etidronate. And for this reason, based on this earlier data, we instituted the TEMP study program. And TEMP stands for the treatment of ectopic mineralization in pseudoxanthoma elasticum. So we already a few years ago, we did the TEMP-1 study. I will shortly go into that study, talk about more about the TEMP-2 study, and we will start the TEMP-PREVENT study in the coming weeks. But before we do any trial, and we heard the discussion already in the presentation from Christina, what is a relevant clinical endpoint? What is a useful endpoint in a trial for PXE? Well, we think that that the arterial calcification is one very objective, standardized, reproducible endpoint that can be used. And from very recent data from my group, we did a study in PXE patients in the Dutch PXE cohort. So in total, 500 CT scans were being analyzed, which was a lot of work from one of my PhD students. And it's a difficult figure, but please note that here on the x-axis, you see the different patients with the according to age. So here are the very young patients, and here are the older patients. And when patients getting older, you see that this calcification of different vascular beds are increasing, especially when you look at the calcification of the legs. You see that this increases over time. And we also measured calcifications in other vascular beds, but the calcification from the legs is very clear that it progresses over time. And this is something we can easily measure by CT scans. So in the TEMP-1 study, we studied this drug etidronate that I introduced earlier in a one-year trial, which was a single-center, double-blind, placebo-controlled, randomized controlled trial. Both the patients and we as the researchers were not aware which drug patients were using. And we measured the arterial calcification of the legs, also the complications if they may occur in the eyes, and also some other laboratory safety aspects. And again, probably the most of you already know the data, but to summarize, we measured a lot of calcifications in all the different vasculatures in the body. But here on the lower right side, you see the total arterial calcification score, which is a summary of all these other vascular beds. And as you can see, etidronate reduces the calcification after 1 year treatment compared with placebo-treated patients. So that led us to the TEMP-2 study cohort because we were interested what are the long-term effects of etidronate, because this is the TEMP-1 study was only a 1 year treatment, but we would like to know the efficacy and also the safety during a 5-year treatment of etidronate. So currently 95 patients are being treated, and we expect the first 2.5 year treatment data in the coming weeks. But when you look at the use of etidronate in the Dutch Expertise Center for PXE, here in yellow, you see the inclusion of PXE patients over time. And here, this first green data is the patients that were being using etidronate in our cohort. And then the study ended, and also etidronate was not available anymore for clinical use. So we had to restart the production first, and that took us some time. And then the majority of the patients in the TEMP-1 study decided that they would like to participate in this TEMP-2 study cohort as well as other patients that were also interested to participate. So here, this second wave or hill, as you can see, are the patients being studied in the TEMP-2 study cohort. And the question we had was based on this period in between. So here at the end of this trial, then one study patient stopped using etidronate, and then we started it again after a few years, and then all patients had a new CT scan. So we could measure what was happening in between stopping etidronate and starting it again. And it is something that we studied in this specific sub-study. So in total, 30 patients that participated in the TEMP-1 study also decided to participate in the TEMP-2 study cohort, as well as 34 patients. And all these patients had a third CT scan after a mean follow-up of 2.5 years. And as you can see, the patients between the two groups are really comparable. So we can compare the results in the etidronate treated patients compared with the placebo treated patients. And here you see the CT scan at baseline in the TEMP-1 study. So TEMP-1 month 0, and then at the end of the TEMP-1 study, TEMP-1 month 12. And then we had the third CT scan, TEMP-2 month 0. And in red, you can see that etidronate was nicely stable over time, where the placebo-treated patients seem to progress, as we also learned in this earlier data that I presented. So it seems that this time period, which was on average 2.5 years, and the efficacy of etidronate is still present. But we think prevention is the best medicine, and also other studies from Lilly showed in the PXE mice that when you treat young PXE mice at the age of 4 weeks already, then you almost completely can inhibit the progression that occurs in the untreated mice. However, when these mice are treated, or when the treatment is started at a later age, so from 12 weeks on, then you can see that there's already quite some calcification present, and that etidronate seems to inhibit that from that point, but the calcification that is already present cannot go into regression, so it will not disappear again. And that gives some interesting insights that prevention indeed is the best treatment, in saying that you should start at a younger age to prevent that these calcifications may occur. And that is something we are going to study in our third TEMP study, which is called the TEMP-PREVENT study, where we will study the efficacy and safety of early etidronate patients in patients younger than 50 years. Also in a double-blind placebo-controlled fashion. We will measure the arterial calcification again, as we think this is a very useful clinical endpoint. We also will measure the calcification of the eyes with techniques already introduced by Christina, and also we have a close look on the safety. The follow-up will be longer, 24 months, and we will start in the coming months. So to conclude, arterial calcification in PXE increases over time, as I showed you in one of the earlier slides, and on average, this is around 15% per year increase. Pyrophosphate is low, as we learned from earlier presentations in PXE patients, and this causes calcification, and more specific, also arterial calcification. And the old drug etidronate is very similar to pyrophosphate based on this molecular structure. And etidronate seems to inhibit the arterial calcification in PXE and also seems to have a long-term effect as this so-called legacy effect. And with that, I'd like to end my presentation, and I'm more than happy to answer any questions you may have.
Great, thanks very much, Wilko. So questions for Wilko? People are getting tired. Wilko, we often get people emailing us saying that should they try to get their clinician to prescribe etidronate to them, and it would be good to have your answer on the record.
Well, the easy answer is it will not be possible as it is not available anymore. But then still, I think it is very important that we learn from etidronate in clinical trials. So in the setting of a clinical trial, I think it will be very helpful. But some single case experience data will not really help us to understand. But again, it is not available in other countries, so it will be very difficult for patients outside the Netherlands to get this drug. And I didn't mention that it's an old drug that is being used for osteoporosis treatment in the past, but now newer, more potent drugs on osteoporosis are being used, and this has led that etidronate is not being used anymore in clinical practice for the treatment of osteoporosis.
Right, and that's why someone asked, why is it not available? The obviously drug developers don't continue to commercialize and produce a drug that isn't being used widely. Is the trial still open? Can people from other countries join? What do you want to say about that?
Yeah, so we will start the TEMP-PREVENT study, and that will be for patients younger than 50 years. So if patients are interested and are willing to participate, living in Europe, I assume, then of course we are more than happy to discuss if that's possible.
And I'm sure Americans will ask, can they participate? And your answer to that?
They are more than welcome, but it will of course be more difficult. We have one Canadian patient that is now being treated in the TEMP-2 study cohort. So we have more and more interest from other people, and they are welcome, but of course it may be more difficult regarding logistics, etc.
Side effects for etidronate?
There are some side effects. So the use of etidronate is in a fashion where we use it for 2 weeks and then 10 weeks off. So these are cycles. So you don't need to use it every day. We did that based on the early osteoporosis data. And part of the patients report that they will have some diarrhea-like side effects, which is also the case in patients using oral pyrophosphate, I assume, because of the digestion in the gut. Some patients have nausea, but that of course will disappear after this 2 weeks. But in general, patients tolerate this drug quite well.
Great. I think that's it. There was one more question I just answered about, are there other osteoporotic drugs available? Yes, they are. Koen, you have a question?
Yeah, very, very nice data. And is there any, so if your studies will be successful, will it be possible to get companies interested in producing this drug for treatment of PXE patients?
Yeah, that's a very good question, Koen, because in the end, we would like that this drug becomes available if it's proven efficacious and safe. So now we now collaborate with a company called Haltex, that likes to help us to get this drug licensed. But what we think is very important is that it will become available for a fair price. So the fair price principle is one of the bases that we like to use, because we know from the past that rare diseases sometimes are being misused by pharmaceutical companies that like to get a very high price for that drug. So there's now one company that that we are collaborating with that helps us with all the difficulties with EMA and FDA, etc. But yes, and if proven efficacious and safe, then hopefully we will get it reproduced again for clinical use.
Because it looks really promising, I would say, right?
Yeah, until now it seems very promising, but I think we need more data, especially on the long-term use that is also asked by authorities like EMA and FDA.
Yeah.
Yes, and one of the challenges, people are asking a few questions about how does a drug get approved. Both EMA and FDA are very interested in the person's experience of the drug and any improvement they feel. And so the scans are a terrific way to measure. And then part of the regulatory assessment will there also be a sense of improvement on the part of the individual? So for example, people will report less pain when walking or resting and so forth. And that's the kind of thing that the regulatory authorities will look for, in addition to good scans that show a decrease in progression.
Yeah, that is what we call PROMs, and that is also what we will use in the TEMP-PREVENT study. So we will measure these kind of patient-related outcomes, as indeed the authorities think this is also very important.
Yep. And again, the surveys that you guys are answering are exactly those patient-reported outcomes, is what they're called by the regulatory authorities. And the more data we have to go with studies like Wilko, and you'll hear from Hubert and Yves also, the better off we are, because we can say we understand this disease and how it progresses. Great. All right. Thank you very much, Wilko.